Hi, Mark.
Hey, Serge, how are you?
Good, thanks. So today we're continuing to talk about addiction and this time about the basic principles of treatment.
Good enough. Um, well, let me start by saying thanks. I appreciate being here, and this is kind of fun. And I wanted to start with, first of all, acknowledging that a lot of what I have to say, as I said last time, is influenced by AA, not completely, and not for everyone. Other big influences were a series of books by Ron Rogers and Scott McMillan. The most direct one is called Don't Help. And their work was based on James Milam, who wrote Under the Influence, which is probably way dated by now, but a really terrific way of looking at alcoholism. Bill Miller, who's a stalwart in the field, and Stephanie Brown wrote a terrific book called Treating the Alcoholic, in which she looked at recovery as distinct from addiction. And very interesting data she got there. And I also have roots in psychoanalytic and humanistic and family systems work, and all these things sort of come together to what I'm about to present to you. The first thing before we even get into treatment is assessment, and assessment is based on I've got a structured questionnaire, which of course I'm happy to share with people if they want it, but it's not any rocket science. Assessment is going over the biological pieces of the addiction, psychological pieces, social, cultural influences, and finally, existential, spiritual dimensions. I tend to use the word spiritual with a lot of people, but for some people, existential seems to fit, so I got to sort of size the person up. Um, that will help you define what stage of addiction the person's at, what category, mild, moderate, severe, and that influences how you would approach the person. Also, the other two things that need to happen three things that need to happen is number one, assessing for any secondary psychiatric psychopathology that not just in general, but if it might interfere with treatment. The general rule is you treat the addiction first, unless there's a suicidal threat, in which case you have to address that first, or if the person is psychotic and can't really profit from the kind of treatment we have to offer around this. Other things need to be noted, addressed. I mean, the gold standard is to treat them both at the same time, but I haven't seen too many places that really are able to do that in any meaningful way. So the question is, the situation is, before you can even deal with any of the psychiatric problems, the person should be clean and sober. Um, the third thing is assessing recovery capital. What does that mean? That means the person's assets, the things that are already exist in their life that will help them work their program, be it abstinence, moderation, usually includes social support, stable living situation, um, uh, financial support. Now, having said that, I ran a program where people were coming in from shelters and they received two tokens when they left at the day, one token to get back and one token to get back to the program in the morning. And a lot of these people did really well. I mean, maybe it was a testament to their desperation and wanting to get out of the shelter, but I think a lot of it was due to the program and the way the program was invitational rather than confrontational. Um, so that's part of the assessment, which will lead into what you decide to do for treatment. And what I'm going to say now applies more towards people in the middle to severe level of addiction, not so much to the mild or early stage person, where you might want to choose a somewhat different tactic. Um, might want to include moderation, might want to include a lot of soft pedaling. Similarly, part of the assessment is looking at stage of change, which I'm hopeful people are familiar with, but somebody who's at a pre-contemplative stage of change requires a whole different type of intervention than somebody who's in the action stage. A person who comes in and says, I don't know, my wife wants me to come here, I don't think I have a problem. Saying, no, I think you should go to two AA meetings a week and see what you think. It's a mismatch. That's a perfectly appropriate thing to say to someone who's in the action stage. Pre-contemplation requires more processing of, tell me what's the good and bad about your substance use. At any rate, moving on, I think three important terms to describe are addiction, recovery, and treatment. And I'll explain why we have to do all three. Addiction, I'm just going to cover in 2 sentences or 2 seconds because we spent time on that on the last talk. Addiction is defined in terms of multiple levels. The level that drives it, once it's in place, the level that drives it is the biological adaptation, including physical dependence, high tolerance, and often the key thing is loss of control, regulated by brain chemistry. That is supported, reinforced, I should say, by psychological variables such as denial, defense mechanisms, sense of identity, learned behaviors fit in that. If you're the kind of guy who comes home from work every day and goes straight to the refrigerator to pop open a beer, when you come home after 30, 60, 90 days in rehab, you walk in the door, muscle memories alone will take you to the refrigerator, and that has to be planned for. And learned associations such as, if I'm with my friend Billy, we always get high, so what are we going to do? That's a social, that's psychological. Social is peer influences. You drive, it's not so much now, but years ago, I was driving down I-95 looking at the bulletin, not bulletin boards, the billboards. And the number one thing they were advertising was alcohol, a little bit of cigarettes, and the second biggest thing was healthcare. And I thought, boy, that's ironic. There's something a little askew about that. But, you know, anywhere you look, there's something glorifying alcohol or drug use. Even anti-drug messages have drugs in them. And the existential spiritual dimension has to do with accepting your limitations and specifically being powerless over alcohol. Something we'll get to the meaning of that much later, but can you control your drinking, or does your drinking control you? To admit that you don't control your drinking is a profound admission of limitation, and that is an incredibly tough thing for most people to acknowledge in our culture, the do-it-yourself culture, you know, the pursuit of loneliness, as Philip Slater called it. And the layers intersect. So the social picture of the alcoholic as a weak-willed person feeds into the psychological defenses, shame and isolation and so forth. That's all I'm going to say about that. The various theories of addiction all have something to say, trauma, brain disease, family systems theory, but I don't think any of them catches the complete phenomenon, and you need to look at all of them in an organized fashion. So that's addiction. Recovery is a loosely defined thing. I mean, in the traditional AA model, it means not drinking and working a program of recovery, including working AA and so forth. The old phrase was that if you stopped drinking but you weren't working a program, you were a dry drunk. And my philosophy was always, well, better a dry drunk than you know, an active drunk. But there's a pejorative when you say dry drunk. Nowadays, it's extended. What about the person who goes to AA for a year and drops out and stays sober? Is that person in recovery? What about a person who goes, I have an issue with this, what about a person who goes to 1 or 2 meetings, drops out and stays sober? Are they in recovery? What about the person who goes from heroin use to marijuana use? Are they in recovery? They won't tell you this in AA, but the fact is that many people, if not most people, will progress naturally to something like that. If you look at the number of people who have an active addiction, and in any given year, let's say 15%, 20% of the population, and then you ask them, have you ever had an addiction? It's like 60%. And I'm guessing at the numbers. What does that mean? It means that there were a lot of people who used to have an addiction who don't anymore. And they didn't all go to treatment. They didn't all go to AA, and they didn't all, get outside help. Um, I have a well, no, I'm not gonna. I have a great story about this, but we'll see if we have time. Um, the so there's I pulled out. There's an article this month in the Alcohol Research Journal put out by NIAAA, and there's an article on what is recovery. So naturally, I had to look at it. Written by Katie Witkowitz. Three definitions that jumped out at me. I'm going to read them. A process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And that's from SAMHSA. Notice there's no reference to drugs or alcohol in there. It's a nice statement about what it means to be a healthy person. The next one is a voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship by the Betty Ford Institute. Reference to alcohol, but only in passing. And CSAT, Center for Substance Abuse Treatment, defines recovery as abstinence and distinguishes between essential recovery, where you're sober, but that's it, and enriched recovery, where you're working on enhancing your life, and spirituality in recovery. They're all reasonable views of it, but they don't, it still leaves the question of a good friend of mine quit doing cocaine. And we got together like, I don't know, 6 months, a year after he stopped, and we had lunch and he ordered a beer. And I said, dude, what are you doing? He said, what are you talking about? I don't do cocaine. I don't smoke marijuana. I'll have a beer now and then. And I said, I don't know if I said it out loud or thought, oh my God, you're on the slippery slope. Well, that was like 20, 30 years ago, and he still has a glass of wine or a beer, never gone back to weed, never gone back to cocaine. Is he in recovery? It becomes a very arbitrary designation, unless you're doing a very classic traditional AA model where continuous sobriety is what counts. You get 5 years of sobriety, you have a slip up one weekend, you start counting your days over again. Now, by the way, the idea of counting days is flexible in that I had a patient who went to Australia on business and went to meetings, and she said that, down there, they don't count days. When you introduce yourself, it's like, I'm Joe, and I'm sober today. It's all it counts today. The other important thing about recovery is that, as I was alluding to before, most people, majority of people manage to recover naturally. And it may be, they get arrested for a DUI and they say, the hell with this, I don't need it. Maybe that they get enough flack about it at home. It may be that they show up at work one day with alcohol in their breath and they're sent home. For one reason or whatever, a lot of people resolve it on their own, natural recovery. Maturing out is what they often say. I think I may have mentioned this last time. Go to any college campus in America and you're going to see a lot of drunks walking around and a lot of people getting high on various things. I shouldn't say drunks. We're not supposed to use that term anymore. But go back 10, 15 years later, how many of them are doing it? About 15% the population. The rest of them, okay, I don't need that anymore. I don't want to act like a 20-year-old now that I'm, 30. It's fine. That's good. Um, Treatment comes in. I often look at it, draw something on the blackboard. Here's addiction. A life of being enslaved to a substance, having a substance unduly influencing your life at least. Here's recovery. Here's where you're just not using, some cases using moderately, life getting better. If you take the idea that most people naturally move from here to there, what stops some people from doing that? And the concept of obstacles comes up. And this is where we do our work. Because what is preventing this person from just going through the natural stages of recovery, which there's now starting to be some research on. And as I said, Stephanie Brown back in her 84 or 85, as far as I know, the first person to do any real empirical work on that. Our job in this situation is to facilitate recovery. And to do that, we have to identify and address obstacles to recovery. Now, I'll give you an example of a case. I sometimes joke around and say, this was my most successful case. Guy comes to see me. He describes a pattern of excessive drinking, and it's getting in the way. His wife's all on him, and work is starting to get aggravated. He comes in, he describes his pattern. He clearly fits all the criteria. I said, man, I think you have an alcohol use disorder. Back then I said alcoholism, but now I have to get up with the trends. You have an alcohol use disorder. And I think for you, the best thing would be to stop drinking altogether. I think for you, it's going to be difficult, if not impossible, to titrate down. And I think that you might want to try AA. And again, back in those days, I probably said, you need to go to AA. And the guy, I don't know, didn't have as much defenses going. And he said, okay, I'll try it. So, and I gave him a list of meetings near him to go. Comes back for a second session. He said, man, that was really interesting. It was really cool. Everybody was friendly. A bunch of guys gave me their phone numbers. They called me up the next day. Who knew? He said, that was really terrific, but I have all these questions. When they talk, say higher power, what are they talking about? I explained a few things. I said, you know what the best thing to do is next time, go to the meeting. After the meeting, talk to somebody and ask them these questions. So get it from the horse's mouth. So he says, okay, I'll try that. And he comes back a third time and he says, listen, AA is just terrific. I don't need you anymore. And I said, yeah, you're right. It wasn't good for building up my practice, but the guy made that transition. He did not have a high level of resistance, denial, whatever you want to call it. He just really was open to it. And coincidentally, I met his wife a couple of years later. It was a fairly common name, so I didn't really make any note of it. She said, "Oh, you worked with my husband 2 years ago." I said, "Oh, yeah." I'm trying to be confidential, but she clearly knew. She said, I said, "How's he doing?" "He's still sober." I said, "Wow." She said, "I tried talking to him years and years. What did you say to him?" I said, "I don't know. I spoke English, and he seems to have heard me." But that's one way of taking the obstacle and just, there was a case where the obstacle was a lack of information. It was a logistical problem. He didn't know there was, I'm sure he knew, he'd heard of AA, but he never thought of it as a viable thing for him, and didn't, he may have heard the term and not known what it was all about. And just encouraging him to go was all it took. Which, by the way, is how I think a lot of natural recovery happens. Your brother-in-law says, dude, I think, why don't you come with me to one of these meetings I go to? That happens. I won't talk about coercion. Another obstacle to recovery is the social environment. If you're hanging out every day in a bar with people who love to drink, and they're all your friends, it does no good for an addiction counselor to say, well, those aren't really your friends, they're your drinking buddies. They're your friends. They may not be deep, meaningful friends, but that's one of the biggest predictors of recovery for men, not as much for women, is developing a sober support system. Getting rid of your drinking peers and creating new relationships with sober peers seems to be a really robust indicator. Um, Psychiatric problems are another problem. If a person is very introverted, has social anxiety, terrified of public speaking, it's going to be a little harder for them to avail themselves of getting support, because I think getting support, whether it's AA or Smart Recovery or your church or just talking to a group of friends, is critical. Um, the whole foundation of AA is one alcoholic talking to another and helping each other stay sober. Um, if you want to hear actually a great story about this, Craig Ferguson, who used to have a late night show, is a recovering alcoholic, and he has one talk he does. It's very funny, it's very moving, it's very powerful, and it's on YouTube, and I think it's called something like um, Craig Ferguson Talks from the Heart. It's about 10 minutes, but it really conveys that. Um, People have such a sense of shame and isolation. The isolation often caused by the shame of saying no one else has this, no one else can understand what I'm going through. Even if they did, I'd be too embarrassed to say anything. And finally, what I consider the biggest obstacle for somebody just naturally going from addiction to recovery, the biggest obstacle is false pride. The sense of I can do it myself, the sense of nobody tells me what to do. I think I mentioned Harry Tebow the last time. Did I mention Harry Tebow? Um, Defiance and grandiosity, two key components of alcoholic personality. Now, whether that has any empirical support, I have no idea. But it really does capture something in the way people with addictions fight their recovery sometimes. Much as they want it, they're ambivalent. Um, One of the key things I learned from Bill Miller about motivational interviewing, and maybe the only thing I remember, is the concept of normalizing ambivalence. People come into your office and they say, I want to quit drinking, but I'm really going to miss my friends at the bar. Man, they really know me. Again, it does you no good to say they're not your friends. If you say, boy, it's going to be hard to say goodbye to them, the person naturally says, yeah, but my liver enzymes are high. He's doing the work for you. I mean, that's basically motivational interviewing, but it starts with the premise that people are ambivalent, and that if you empathize with the one side of the ambivalence, the other side will rise to the occasion. It's not as simple as playing reverse psychology, which it sometimes sounds like. Okay, obstacles to recovery. I got my cheat sheet here. Defiance, grandiosity, false pride. Assessing recovery capital, which we talked about earlier. What does the person have going for them? 90% of the time, there is someone in their life who's in recovery, and they may not even know it. Maybe a relative, maybe a friend. They may notice that their pal is not drinking anymore, but hey, that's more for me. They may say, hey, where's Bill been? He's not hanging out in your basement anymore getting high. Oh, well, if people reach out or make it known that they have a problem, they get support from their social group. They get support from their peer group. It's important that, I mean, the more the person has a stable living situation, the easier it is, the better it is. But as I said before, we work with people who are living in shelters or in, total drug infested neighborhoods who manage to make a go of it. Um, Most important is the capacity for personal stability. If the person is labile all over the map, it may be really hard for them to get it, and you will have to work with that. But you're looking for signs of strength and stability and building on those. You're building on the natural strengths. First time I heard the term dual diagnosis, literally the first time I heard it, I was running an outpatient program, and somebody called and said, "Do you handle dual diagnosis patients?" And I, trying to be cool, I said, "Well, it depends what you mean." Well, here's a person who has a lot of depression and might have bipolar disorder. I said, "Well, can they sit in a chair and listen?" "Oh, sure." I said, "Then they can come in." You know, that's all that matters. If the person's really, bipolar, labile, and running around the room throwing paper airplanes, that's not going to happen. That's not going to work. As long as they can participate, I think they're good enough to go. When you have someone who really has a legitimate secondary diagnosis, that requires some special attention. And a lot of programs offer some specialized treatment for that that's hopefully integrated with the recovery work. Um, and let me see, I think the last thing I wanted to mention about this was that what you're also working on is establishing a broad goal for treatment. And by that I mean, are you working on abstinence or are you working on moderation? And I think I alluded to this the last time. Person may come in and say, I've got a drinking problem. I know I do, but I really don't want to give it up. I really like a fine chateau blah, 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 with a steak. I have one guy I remember had a extensive wine cellar in his basement, and I don't want to give all that up. I just want to cut back. Well, okay. And I always throw this line in almost as a risk management thing. Well, if you don't drink, you won't have a drinking problem. So I'm sort of advocating abstinence, but people who want to moderate, they want to moderate. What I usually tell them, because this is what the moderation program suggests, is look, can you do 30 days of sobriety before you start the moderation program? Let's get a baseline. Let's see if you can do it. If you can't do it, maybe we need to up the ante a little bit. Now, some people work on a moderation program, and it's a program. It's not saying cut back. It's defining how many drinks is too many, staying below that limit. How many days a week are you going to drink? Slow down your drinking. I have one of the tools there, which I really like, is make every drink last 15 sips. Make every drink last an hour. There's various tools for moderation. Some of the people are able to do that. God bless them. Then they're normal people, so to speak. Some people are not able to do it. And the most frustrating thing is the person who falls on his face once and says, "Oh, wait a minute, I won't drink hard liquor, I'll drink beer." Comes back, falls on his face again. I think the problem was I was drinking those IPAs, so I'm going to drink regular beer. Regular, can be anything. I'm drinking bourbon, but I'm going to switch to vodka because it's clear. And you get to a point, and typically I will say, look, if you can't manage it, which is no shameful thing, if you can't manage it, we'll have to talk about a higher level of care, be it rehab, be it more intensive outpatient or something like that. And the frustrating scenario is when the person fails every test and says, "I want to try one more test." And how much do you go with that? And how much do you say, time out, you've used your chances? That's an uncomfortable position to be in, but you have to be sometimes. So that if the person wants to do abstinence, yeah, AA is a modality. I have a number of people I work on. I do a lot of AA type intervention, but they don't want to go to a meeting. They don't go to a meeting. I encourage them to do a lot of the things that you would do in AA. Look, anybody you owe money to, pay them back. Don't hang around with your friends. Okay, I have to tell you the story. And I'll make it really quick. I met this guy. He was a bouncer at a very notorious strip joint in Manhattan, and very nice guy. Um, out of context, the story isn't quite. But anyway, he said, "What do you do for a living?" I said, "I'm a psychologist. I work with a lot of people with drug and alcohol problems." He said, "That's so funny. I quit drinking myself." I said, "Really? How long?" "Oh, 8 months." "I'm curious. How'd you do it?" He said, "Well, I realized I was drinking too much. I realized it was getting in my way. So I made a decision to stop drinking. And I went and I talked to my priest, my godfather, and my father. And I told them what I was doing. And then I went around, and if I had screwed somebody over, I apologized. I paid back all the debts I owed. I started going to the gym. When my shift at the bar was over, I left right away. I didn't go hang out and go after hours." So he was doing anything that anybody would have told him to do. And he maintained sobriety. And this guy has some minor celebrity, so I know he's still sober. And this was 20 years ago. The ironic thing is that I then saw an article in the newspaper, and I don't know how I saw this, that he was sentenced to jail because he was an enforcer for the Gotti mob. And then I thought, he spoke to his godfather. He spoke to the godfather. He spoke to Gotti. And I thought, wow, I never went to an AA meeting, never did anything remotely. I mean, I guess he went to his priest, so he had spiritual oriented. At any rate, that was fine. That he didn't follow the approved protocol. Anyway, let me move on. Primary issues in treatment. What comes up in treatment? I often think the biggest piece of this is guilt and shame. The guilt and shame, the shame in particular, prevents people from getting help. They just don't want to admit it. They just don't want to see it. They're afraid other people will see them. I can't go to an AA meeting. I mean, it's right down the street from my block. People are going to see me go in there. Geez, maybe you should find a meeting in the next town. Oh, they still don't want to do it because there's a resistance to admitting it. I think it's important to distinguish between guilt and shame for a moment. And I don't remember if I did this last time, but again, shame is the real driving force here. It's like, I can't show my face in public. I can't stand who I am. Guilt is, I really hate some of the stuff I did. And the problem comes when people confuse those two levels. And I often say to people, what you did in your addiction does not define you. Do any of your mistakes define you? I imagine there are some people who will have something that is in their past that defines them. Are you a person who committed a murder, or are you a murderer? Well, I leave it up to them to decide how they want to phrase it. But if I ask a patient, of all the things you're embarrassed about in your life, how many of them did you do when you were under the influence? And the universal answer is all of them. All the things that they're embarrassed about, ashamed about, were a factor of the substance use. And again, I may be repeating myself here, but what's left over from what the bad stuff you did in your addiction is just the normal stuff that we all do. I recently had a patient who, upright guy, wants to be in the CIA or the State Department or something. And I said to him, "Have you ever shoplifted, pack of gum?" "Oh, no, never." And I'm thinking, this guy has, obsessive compulsive personality disorder, which I don't think he has, or he's lying to me, because, people do stuff like that when they're kids. And again, the metaphor I use is, if you don't want to fall off a bike, you're never going to learn to ride it. Falling off is the process of learning. At any rate, what I'm trying to do there is to separate the shame from the guilt and get them to see guilt as a way of learning. Guilt is nature's way of saying, don't do that again, or you're going to feel this lousy feeling. Um, Shame does not exist. Shame is an artifact of distorted cognition. So we deal with the shame. The other way of dealing with the shame is by normalizing that everyone feels guilty when they start to get sober. There's a lot of fences that need mending. You don't have to feel ashamed about it. You just have to do it. You just have to fix the fence. Um, the um, the other thing that you deal with in terms of shame is introducing the idea of the disease concept. That your addiction is a disease. You're not a bad person trying to get good. You're a sick person trying to get healthy. Now, lots of people will fight you on that. I don't believe it's a disease. What gene is it? And, all this kind of stuff. And sometimes I take a flippant response and I say, well, you know what? I don't have the answer, but it's you. Um, take it from me for now. Um, Normalizing it, go to an AA meeting and look around, and you will see all these people who are the same as you in many ways. I had a guy who, well-to-do guy, he built himself up from nothing and really was well. Drove Jaguar, I remember. Went to once a week. He would go to an AA meeting in a homeless shelter downtown because he wanted to remember where he'd come from. And one day he was there and he was sort of daydreaming, and he heard this woman across the way telling something, and he said, "Holy shit, that's my story." And here's this well-to-do white guy, and he looks across, and it's a homeless black woman with her bags, with all of her possessions. And he thought it was like a mystical experience that he said, I and her are the same person.
Mm.
Now that's a pretty extreme, but the notion that you're sharing a lot in common with these people is such a liberating, de-shaming process. One more vignette. A guy comes to the first group, and there's another guy who's in the group who's sitting in the waiting room. And the new guy comes in and says, what do I do? I said, grab a seat in the waiting room. And he sits down next to this guy who's in his three-piece suit. The new guy says, are you the therapist? And the guy looks at him and says, I'm a drunk, just like you. And by saying that, it took all the pejorative quality of it. And they both laughed. It was a really great moment. Um, Establishing community is another key way of diffusing shame. And I often think about that scene in Good Will Hunting, which everybody, when it first came out, everybody said, oh, you got to see it. This guy looks just like you. When Robin Williams is taking Matt Damon against the wall and saying, it's not your fault. And Matt goes, yeah, I know. He says, no, I mean it. It's not your fault. Until finally it breaks through. It's a very powerful scene, and I think has a lot of the philosophy of what I'm trying to convey to people. The other important thing is instilling hope. Do you think this can ever change? No. Even with a lot of work, maybe a little. Bingo, we're getting there. And mainly to maintain a therapeutic alliance, that the person feels that by working with you, there's some hope. Because even if things go rocky, they still come back to you. If the moderation plan fails, they'll say, okay, this ain't working, doc. Last but not least, a couple of words about the process of therapy. In the initial phases, a lot of what you're doing is education. You're telling a person what the disease concept is. A lot of what I did on the last talk is exactly what I do with patients. I will pull up a PowerPoint if I have my computer, or I'll draw it on a blackboard if I ever had an office again. And I will describe that stuff so that they understand what it is they're dealing with. I tell people, if you think Chicago is that way, and you spend 2 days walking that way, you could have been sincerely working something, but you're going in the wrong direction. You're not going to get there. to know what it is you need. If you think that what's wrong with you is um, poor moral fiber, you're not going to take appropriate action. So early in treatment, education, you're teaching skills. I think I mentioned the book Living Sober, terrific little book by AA with all sorts of little common sense tools for how to live sober. You help with problem solving. It's, for people who are used to doing in-depth therapy, this feels like I'm doing just superficial stuff. It's very important at that stage. As therapy progresses, it deepens. And as it deepens, the focus shifts from drug, alcohol, to self. And particularly self as related to other people and self sense of identity. It's a very different feeling to say I'm an alcoholic to say I'm a recovering alcoholic. It's a whole different connotation. And a lot of people take a lot of pride and solace in being a recovering alcoholic. In fact, in some AA meetings, you hear people say, I'm a grateful recovering alcoholic. Because the program has expanded their world, their view of themselves, their view of community, their view of their fellow personhood. And that was what Stephanie Brown wrote about in '84.
No, let's just take a moment. Let's just take a moment to see what else we might do.
Well, I have one other thought that came to mind, which is that
yeah.
as a psychologist, and I'm not recovering from drug and alcohol problem, I used to be terrified that the patients would say to me, are you in recovery? Because once they ask you that question, the agenda is, so what do you know? And no matter how you answer that question, you don't win. If you say, no, I'm not, but I've been studying this and working with people for years, yeah, but you haven't walked the walk, have you? If you say, well, tell me why that's important. Oh, you don't want to answer the question, do you? How can I trust you if you don't, every time they ask you that question, it doesn't go well. What I've noticed is that people don't ask me that question very often anymore. Partly because I think I know what I'm saying and people get it, but the one answer, and I haven't really had to use it very often, the one answer I've developed that addresses that is a person says, are you in recovery? I say, I think that's the wrong question. The real question is, can I help you? Stop them dead in their tracks. Now, there are ways around that too. You say, why do you ask? They say, oh, I'm just curious. Bunch of crap. The biggest problem with this is the self-consciousness of the therapist, going along with that whole belief that only an alcoholic can help another alcoholic. Well, as far as the AA rooms go, yeah, but that's not true in general. I like to think I've helped a few people without having walked in the, through Kensington looking for a score. But it's something that people are often very nervous about. If it comes push to shove, I say, no, I'm not, if I'm in a funny mood, I say, well, based on this, what I did in the 60s, I should have been. Just good luck and good genes. And I never got sucked away, as a couple of my friends did. So I hope that addresses that piece of the treatment dilemma.
Yeah. Thanks, Mark.
Thank you.